Well, morena, everyone. My name's Natalie Scholl. I'm a psychiatrist. As was mentioned, I work at the Community Alcohol and Drug Service, and I also work at Liaison Psychiatry at Auckland City Hospital. Just make an acknowledgement, first of all, to the organisers. Thank you for inviting myself and my CADS colleagues, and I do see some of them here in the audience already. And thank you to the organisational team, because it's been smoothless and extremely helpful to have them in the background working on supporting all these speakers today. And also thank you to you all for coming in on a Saturday morning and spending your own time and I'm sure what's very busy circumstances for you both personally and professionally. So great to see you all here. I was asked to speak on the topic of substance use and ageing because I did work in a specialist team in CADS that specifically focused on older adults. But I also, in the hospital, was seeing people, older adults in particular, coming through admitted acutely and having perhaps a less than ideal trajectory through that inpatient setting. And when I started working with the older adults in CADS, which was about 9 years ago now, there was a real sort of concern about the ageing baby boomers coming through. And there was this worry that was going to be this big wave of baby boomers who might be continuing their previous youthful patterns, perhaps, of increased rates of substance use. As they move into older adulthood. And this is sort of typified by this quote here by a baby boomer himself at the time, or he was still a baby boomer, but just into older adulthood, suggesting that this would be the case. And so there was high levels of kind of concern that we weren't prepared for this and what we were going to do in the sector and more generally. However, the wave didn't really arrive in terms of illicit substance use. And what we continue to see really is that alcohol is the primary issue of concern for older adults. Well, in the population in general, but also for older adults. So that's what I'm going to focus on specifically today. And your health pathways, which I had a look at and are very good, does mention older adults as a demographic group of concern. So as I've sort of circled and highlighted there, it notes that hazardous alcohol use has worse outcomes for older adults compared to other adults, and that the prevalence or the presence of even severe alcohol use disorders is often underestimated. And there's probably lots of reasons why that might be the case. And, the Royal College in the UK, Royal College of Psychiatrists, I should say, we got quite exercised about this, and they created this document, which I would recommend. It's quite lengthy, but if you have some time, in addition to all the CME you're doing today already, it's a good read. They've put out 2 versions of it, so this was the 2018 version updated, really identifying that this is a group that often is missed, and it speaks to the need for a real focus on systematic screening, identification, and sort of specific planning for older adults with alcohol and substance use issues. And as an example of this, it talks about how in the UK specifically, up until 2010, older adults were explicitly excluded from many of the population surveys that were being done to estimate prevalence rates of alcohol and substance use in the community, which then makes it hard to use data to actually plan for and put in place services that this particular group needs. So that's something, if you want some further reading, bedtime reading, to have a look at. And the other reason that this is important is that we all have seen pictures like this or graphs like this that show the currently underway and continuing to intensify changes in the demographics of our population, and so that not only are we going to have a much larger group of older adults, as you all know, but we're going to have a much larger group of older adults as well, and so it's a hugely sort of dramatic change in the landscape. So the health pathways mentioned that older adults suffer much more harms from problematic or hazardous substance use or alcohol use. And this graph, which again is UK data, does sort of demonstrate that in action over time. So what you have on the left-hand side of the screen is the rankings of a number of risk factors for disability-adjusted life years. And you can see alcohol use back in 1990 was considered number 61, so that's not a linear scale on that side. And then on the right-hand side, updated in 2017, alcohol use has jumped from number 61 to number 18 for over 70-year-olds in the UK. So that's quite a significant change. And obviously right up at the top there, you've got smoking and a lot of the other metabolic risk factors as well. And in addition to that under recognition, the Health Pathways section on older adults mentions that it's can be under-recognised or underestimated. And so this, again, this is NHS data from Public Health England in 2018, and they looked at secondary healthcare settings. So they did a review of discharge paperwork over a several-year period, and they found that over 65-year-olds accounted for 30% of alcohol-related admissions to hospital. But of that 30% of older adults, only 30% of those ended up having their alcohol use disorder formally recognised as part of that discharge paperwork. And this also comes to the practice point that's within your health pathways around this issue, that you need to be keeping in mind the possibility of an atypical presentation of an alcohol use disorder, and particularly for older adults. They're not necessarily going to present in the same way as a younger adult who may be more overtly impaired and getting into difficulties in the community. Because one of the things we do know about older adults is they're much more likely to drink at home and to drink on their own. So they may not come to attention as readily, and they may present in a slightly more atypical way. This is also a slightly sort of worrying graphic, again, UK data, about the change in trends over time in people who are categorised at drinking at lower risk. And they've looked at it by the age bands across the sort of lifespan. And you can see from that that the over 65s are the groups over time that seem to be rising in prevalence in terms of drinking above what's considered lower risk limits, which suggests, you know, there is a need for a particular focus on this group. So what do we know about the epidemiology in New Zealand? Well, thankfully, a group has put out quite a lot of data in recent years based on the New Zealand Work and Retirement Longitudinal Study. They surveyed over 4,000 New Zealanders over 50 years of age. I guess that's considered when people might start retiring. And they looked at a lot of data in this area. But key take-home message, I think, is that New Zealanders get the silver medal for having the second highest proportion, I should say, of people, older adults who are drinking, full stop. You know, and that we're well ahead of the next group of countries who are behind in third and subsequent places. I keep wanting to do that. And what they also showed is that hazardous drinking generally is quite stable across the lifespan. So the majority of people who drink hazardously early in life drink hazardously potentially in their older years. And I've just had a 5-minute warning sign, I think, is that right? So I'm going to have to speed up. Sorry about this, because there's quite a bit to cover. The hazardous rates in New Zealand are between 35 to 40%, depending on the screening tool that you use. And I think a particular point to take away is that hazardous drinking rates were nearly 50% in men, older adult men, no matter what screening tool was used. And that, as we mentioned, older adults are at higher risk of significant harms. Good news in terms of the Māori population who was surveyed here is that they had similar rates of hazardous intake overall, and they were drinking slightly less frequently, although slightly higher quantity when they were consuming alcohol. So screening is a big question in older adults, what tool to use, when to do it. and people get quite worried about it. The research really shows that the Audit C, which is the recommended screening tool in your health pathways, is actually relatively helpful, relatively useful in terms of identifying older adult drinkers who may be drinking hazardously. And if you adjust the threshold from 5 down to 4, you're going to pick up almost all of the hazardous older drinkers who you would using a much more sophisticated sort of research specialist tool. I'm going to quickly whiz through these next few slides, but obviously there's key risk factors. Older adults have physiological changes that make them more at risk of the harmful effects of alcohol, both sort of muscle mass distribution, metabolism through the renal and liver system, but medications are a big factor as well to keep in mind. So this is local data from New Zealand looking at prescribing of potentially concerning medications in older adults in combination with alcohol. So you look at here and you can see that there's a small increase, but there's an increase over time between 2010 and 2015 of prescribing rates of, that's combinations of either an opioid and antipsychotic or an opioid and a sedative. And it's the older adults group who has the highest increase in that prescribing rates. So we need to be really careful when we're thinking about the risks for older adults of the combination or potential combination of prescription medications and alcohol. I did want to briefly touch on alcohol withdrawal. We know that older adults are more vulnerable to developing delirium tremens, and that's partly just an age, but it may also be duration of their alcohol use disorder. There also is some evidence to show they may be much more at risk of Wernicke's when they're in hospital. We know that their duration of withdrawal symptoms tends to be longer than the younger adult population, so on average closer to 9 days rather than 6 or 7. And we know that they also get more concerning symptoms that might put them at risk of things like falls or confusion. And obviously, cognitive impairment or alcohol-related brain injury is a key concern for everyone with a significant alcohol use disorder. But older adults have, again, that particular vulnerability in terms of their physiology and other medical factors that may be a concern. As a psychiatrist, I'm also obviously very interested and focused on some of the links between alcohol use disorders and mental health concerns. And the key takeaway points here is that there's a really strong association in older adults between alcohol misuse and depression, and that's unchanged in the strength for older adults compared to the younger adult population. And older adults who are presenting as depressed are 3 to 4 times more likely to have an alcohol-related problem than those who are not. So they are a key group to be screening in your practice when someone's coming forward with depressive symptoms or you're treating them for depression. It obviously confers a higher risk of suicide, as it does in the general population if you have depression and an alcohol use disorder. And an interesting point is that the older adult age group seems to be the least aware of in the population of the association between alcohol and depression. So some education and information and advice giving could be helpful on that front as well. So the health pathways, I think in terms of how you might approach this in your daily practice, it really gives that useful ABC approach. And I think often people wonder about the benefits of advice giving or information offering for the older adult group for various reasons, but the evidence is that brief interventions are as effective in the older adult group as they are in the younger. So, focus on the steps and the strategies that the health pathways are outlining and suggesting. And there's lots of really useful resources on that Health Pathways document that you can link into just to upskill or increase your confidence in using those. In the specialist setting, obviously we have a few more sort of options available to us. I'd really encourage you to think about early referral to detox services if you have a concern or if someone's screening at a concerning level in terms of the Audit C, or if you then proceed to a full audit. We think about pharmacotherapies a bit more, but I personally don't use disulfiram very often in the older adult group just because of some of the risk factors. But people should be offered naltrexone if they're meeting the special authority criteria, which at this stage unfortunately means they have to be engaging in a formal treatment program, which generally means CADS. So we're happy to see people and assess people if they're willing to engage. And sometimes there's a bit of sort of therapeutic nihilism about psychological therapies for older adults. And I'd really say that, the evidence is limited because older adults are not often included in research in this area. But what is out there suggests that it's actually as effective, and we shouldn't be dismissing that as an option for older adults. I also recommend this booklet. You may have seen it. It's a booklet. It's not an information sheet, but there's lots and lots of useful, well put together and well summarised data and information in there. So that's more for patients rather than clinicians. And the take-home message that I would say is, keep in mind that this is a vulnerable population group, that your standard screening tools are completely acceptable and helpful and valid, so do those. Think about men, think about those who are depressed, and think about people who've had repeated presentations to hospital. The harms are significant, and as health professionals and prescribers, we need to keep that in mind when we're seeing people with complex medical and polypharmacy issues. And that treatment can and is effective if people are referred and can be engaged in those avenues. So that's it from me.